Hi guys, this is Ada Ojaid from NPPA Learning TV. This video will focus on test-taking strategies on hypertension for MP and PA boards. This video is focused on the important concepts or highlights an advanced practitioner should know to successfully answer questions on hypertension. The theme of the video is skewed more to primary care. We will address inpatient management in subsequent videos. Thank you guys. Basic concepts for success in test taking. For success on tackling hypertension questions, it is important that you know the current guidelines, patient demographic, epidemiology, risk factors, clinical features and diagnosis, treatment and management. I'm going to elaborate more on treatment and management. Treatment include treatment modalities such as initial treatment, when to use secondary agents, when to refer, or specialized interventions. As a matter of fact, treatment and management overlap. With management, you should know basic principles of management, monitoring parameters, and caveats with management. Guidelines. JNC 8 versus AHA guidelines. This is an excerpt from Tufts University School of Medicine. This is also the evidentiary critique of both guidelines. At this point, it will be okay to pause the video to carefully go over the tables. These are just highlights of the evidence abstracted from both guidelines. The most important thing to note or focus on is the clinical endpoint and the validity, quality, or strength of both guidelines. BP target from JNC 8 and AHA. At this point, I encourage you to pause the video in order to carefully go over the recommended BP target. The table is a comparison of both guidelines. Although the novel consensus on BP target is based on AHA recommendations, these medical organizations, namely AAA, FP, and ACP, do not endorse AHA guidelines because they feel that it has low evidentiary strength and possibly poor exclusion of bias because the chairperson of Sprint trial was affiliated with AHA. However, for the continuum of hypertension management, AHA is the most current guideline and is here to stay. JNC 8 guidelines. For individuals taking the AMP, please familiarize yourself with the guideline as it is part of the exam blueprint. Pay particular attention to the age-specific treatment for exam purposes. Classification of blood pressure. The following table depicts the AHA blood pressure categories of classification. It is highly important that you have a firm understanding of the blood pressure categories. For the rest of the presentation, I encourage you to pause the video to go over the tables, depicted diagrams for further knowledge and understanding. AHA algorithm for BP management. Please pay proper attention to the schematics on when to initiate treatment and evaluation specifics. Be sure to familiarize yourself with the algorithm as it is a very important tool for clinical management of hypertension. Key concepts from treatment guidelines. So I made this table or schematics to help anyone who has problems in mastering treatment guidelines from AHA. I hope you find it very helpful. I feel like it will help internalize the specifics of AHA guideline. Please pause the video and carefully go over these tables. Key concepts from AHA guideline. Key takeaway from AHA include the following. BP target of less than 130/80 for all hypertensive patients, with considerations for certain population specific. ASCVD risk greater than 10% necessitates initiation of treatment. ASCVD risk less than 10% with BP of 140/90 needs drug therapy. Age greater than 65, adult non-community dwellers require treatment for BP greater than 130. And the target BP for this population is less than 130/80. However, adults greater than 65 with lower life expectancy and in institutionalized setting, treatment should focus on clinical judgment, patient preference, and risk-benefit effects. A little bit of a disclaimer or side note. For individuals taking the AMP, both AHA guidelines and JNCA guidelines are part of the exam blueprint. For those taking ANCC, AHA guideline is the only guideline you'll be tested on. Important pearls for exam success. Know the appropriate BP measurements for clinical diagnosis. Know the AHA classification for blood pressure. Know how to identify and exclude secondary causes of hypertension. Know the clinical features that indicate end organ damage. For example, AV-Nikken or hypertensive retinopathy indicates prolonged elevation of blood pressure for greater than 6 months. Know the non-pharmacological approach such as lifestyle modification as first-line treatment for initial presentation of elevated blood pressure for patients with BP greater than 130/80 and ASCVD risk less than 10%. The 2017 American College of Cardiology and American Heart Association guideline recommendations stipulates a target BP measurement of less than 130/80 for all hypertensive patients. Under pearls, it is important to know that AHA also recommends that stage 1 hypertensive patients with BP of 130/80 to 140/90 with ASCVD risk of greater than 10%, meaning that they have atherosclerotic cardiovascular disease, necessitates drug therapy initiation. To further explain, treatment with antihypertensives should be offered to patients with BP 130/80 or 140/90 with ASCVD risk score of greater than 10%. Know the recommended treatment for stages of hypertension by task forces JNCA and American Heart Association for the AANPCB boards. Remember that AHA is the most current guideline. Target BP for all conditions for AHA is less than 130, with considerations to age and life expectancy. Know the compelling indications with drug selection. For example, what antihypertensives to prescribe for a patient who is hypertensive with MI, migraine, heart failure, and CAD. Under pearls, it is important to know the relative and absolute contraindications with drug selection. For example, cardioselective beta blockers can be used for asthma. If the answer choice has non-cardioselective beta blockers, then it means that the theme or stem of the question is indicating that a non-cardioselective beta blocker is contraindicated. Also know that ACE inhibitors are contraindicated in bilateral renal stenosis because it dilates the efferent arterioles through the inhibition of angiotensin II, a potent vasoconstrictor. This results in reduced intraglomerular perfusion and renal insufficiency. Know signs and symptoms of ruptured abdominal aortic aneurysm, and when to screen for abdominal aortic aneurysm. Note that ambulatory BP measurement is indicated in individuals with white coat hypertension and normal BP measurements at home. Target organ damage in hypertension. The following images depict target organ damage from hypertensive retinopathy. These include flame hemorrhage and AV nicking. Also, cardiomegaly, stroke, and renal failure are other common target organ damage from hypertension. Now onto my favorite part of the presentation, case questions. Case question number 1. A 61-year-old Asian female presents to your clinic for a physical. However, her blood pressure measurement is 160/88. Her physical exam was not remarkable for findings. She reports taking over-the-counter supplement. What is the best initial management? A. Recheck blood pressure. B. Initiate ambulatory BP. C. Begin antihypertensive regimen. D. Obtain EKG. Case question number 1, analysis. Important concepts to note regarding the question include the patient specifics, such as a 61-year-old woman, blood pressure measurements that's elevated, 160/88, physical exam that's unremarkable, and the question, what is the best initial management? This is a throwaway question. It's kind of like a throwaway question. The question is based on the assumption that the office protocol for elevated BP was not carried out. It's possible that the MA maybe was really busy and forgot to recheck the blood pressure. This question is just a basic introduction for someone not familiar with the specifics of blood pressure measurement in hypertension management. So it's like a basic 101 for someone who is not familiar with what to do when the blood pressure is initially elevated. Furthermore, the premise of the question is to clue the test taker on what to do when initial BP measurement is elevated. The best answer to the question is A. Recheck blood pressure. Diagnosis of hypertension is never done on a singular blood pressure measurement. It requires repetitive measurements of BP of up to 2 to 3 consecutive visits before a proper diagnosis can be made. Patient must be seated comfortably and allowed a rest period of 5 minutes. If BP is elevated for 2 to 3 consecutive visits, and ASCVD risk is less than 10%, then lifestyle modification strategies should be initiated. Other answer choices are only required if there is a compelling indication. For example, you would initiate ambulatory BP measurement if the home BP differs from office BP measurements. Case question number 2. Mr. Bunvey is a 63-year-old African-American male with a history of stage 2 hypertension and hyperlipidemia. Current medications include thiazide diuretic, calcium channel blocker, and moderate intensity statin. He was recently diagnosed with CKD stage 2. Physical exam was unremarkable. 10-year ASCVD risk is greater than 10%. However, a decrease from previous measurements of 12.5%. Both office and ambulatory BP logs averaged 135/85. Which of the following pharmacotherapy is most appropriate for Mr. Bunvey? A. Aldosterone antagonists. B. Non-dihydropyridine calcium channel blockers. C. Centrally acting sympatholytics. D. Cardioselective beta blockers. E. ACE inhibitor, lisinopril. Case question number 2, analysis. Let's deconstruct this question. There's a lot to unpack from this question. Like I mentioned previously, it is important for you to know the basic concepts for success in answering hypertension questions. First, I would note the patient demographic, past medical history, current medications, any compelling indications, ASCVD risk, BP measurement, and the stem of the question. One of the compelling indications from this question is CKD stage 2. The premise of the question is for the test taker to determine the most appropriate therapy or best antihypertensive to prescribe for patients presenting with CKD. Per AHA and JNC8 recommendation and evidence, and also taking into consideration current medication list, the best pharmacotherapy for CKD is ACE inhibitor, lisinopril. However, caveats with lisinopril is that it increases serum creatinine, so careful monitoring of renal function is necessary. Other answer choices are incorrect, not recommended, and will portend adverse effects for the patient. Case question number 3. Mr. Abathy is a 57-year-old Caucasian male with a history of anterior wall MI and stage 1 hypertension, presenting with chief complaints of irritative voiding symptoms. Patient reports weak urine flow, nocturia, prolonged voiding, and slight discomfort and straining during voids. Urinalysis is negative for nitrites, leukocyte esterase, and microscopic hematuria. AUA-SI index is greater than 10, which indicates moderate BPH. Current drug regimen include carvedilol, Plavix, low-dose ASA, lisinopril, and high-intensity statin. Which of the following medication would be most appropriate to add to his regimen? A. Prazosin. B. Tamsulosin. C. Finasteride. D. Oxybutynin. Case question number 3, analysis. Referring back to our basic concepts for test taking, main concepts to note include patient specifics such as anterior wall MI, stage 1 hypertension, chief complaints of irritative voiding symptom, negative UA, and AUA-SI index greater than 10, which indicates moderate BPH, and current medication list. The premise of the question is for the test taker to determine what is the best medication to give in the situation of moderate bothersome BPH. The best regimen is an alpha blocker, which is recommended as first-line therapy. Although prazosin is an alpha blocker, it is not recommended due to insufficient evidence. Tamsulosin is the best answer because it is recommended by AUA, and it is also a selective alpha-1 blocker. It carries a lower risk of first dose syncope. All other answer choices or regimen require a compelling indication or confirmation of progression of BPH or a secondary evaluation from a specialist. Thank you so much. Please make sure to review the presentation and pause the video for more understanding. On that note, I just want to say this. You are a valuable member of the healthcare team. Success begins when you dare to dream and refuse failure. You got this, guys. For more information concerning hypertension management guidelines and other disease process, please check out our Advanced Practice Virtual Classroom on Facebook. We also have a comprehensive review for FNP and AGMP boards. The links to all our platforms are in the description box. I just want to say thank you for watching. Please subscribe to our channel. Have a nice day. Bye.